pericardium. The pericardium is the sheath or the coverage that is surrounding the heart, and you can see it here, that is normal, and here is inflamed. So that coverage that surrounds the heart, when it's inflamed, we call it pericarditis. Typical presentation, they come with chest pain that is worse with inspiration, coughing, leaning supine, and gets better with sitting and leaning forward. And it makes sense that it gets worse by inspiration or coughing or leaning supine, because this is how you stretch the pericardium. And once you stretch or move the pericardium, then chest pain occurs. There are other symptoms like dyspnea, palpitation, they might come with fever, but generally the hallmark is the chest pain that is worsened by inspiration or cough and better with sitting and leaning forward. So what causes pericarditis? Idiopathic, might be unknown cause, could be viral infection, the Coxiella virus, echovirus, cytomegalovirus, herpes simplex, HIV, or bacteria like staphylococcus or tuberculosis. Could be following myocardial infarction, whether from the myocardial infarction itself or following surgery. Could be uremic pericarditis, post-traumatic injury, whether a trauma or surgery as well, malignancies, autoimmune disease like SLE and rheumatoid arthritis, medication like hydralazine, phenytoin. So what are the complications of pericarditis? Constrictive pericarditis, which makes a lot of sense. Constrictive pericarditis is a thickening of the wall. Once it's inflamed for a prolonged period, then it will become thickened and fibrosis, and once it becomes fibrotic, we call that constrictive pericarditis. Pericardial effusion, which is the accumulation of fluid in the pericardium, and once that fluid starts to put pressure on the heart and impair the functionality of the heart, we call it cardiac tamponade. So what are the diagnostic criteria for acute pericarditis? So the typical chest pain is the first one, and that's the hallmark, which is sharp or stabbing chest pain that's worse with breathing and improves with leaning supine. Worse with leaning supine and improves by leaning forward. Frictional rub, which is like friction or rubbing or a mechanical sound when you hear it on the auscultation. Suggestive ECG, which is widespread ST elevation with reciprocal depression in AVR and V1. This is a very good ECG here. As you can see, there is widespread ST elevation in mostly all leads except AVR and V1. And the most specific is PR depression. And as you can see, there is PR depression here, except in AVR and V1. Here is not very much in V1, but you can see here that the PR is elevated. So widespread ST elevation with PR depression on all leads, except AVR and V1. Obviously, not every ECG will come this typical. They might come only with widespread ST elevation. So the suggestive ECG, widespread ST elevation with reciprocal depression in AVR and V1, and PR elevation in AVR and V1 with depression less of the leads. And new or worsening pericardial effusion and echo. So 2 out of these 4 criteria makes the diagnosis of pericarditis. Myocarditis, which is there is already inflammation of the heart, and it means that the heart got damaged, so there will be elevated cardiac enzymes like troponin, and focal or diffused left ventricular dysfunction on an echo or any cardiac imaging. Obviously with absence of other causes. So when does pericarditis gets hospitalized? Obviously every case is different, and there are other indications, but these are general indications to hospitalize if there is fever above 38, evidence of cardiac tamponade, subacute courses. Obviously, if there is large pericardial infusion, patient on immunosuppressant, anticoagulation, acute trauma, fails to improve, or evidence of myocarditis, means that the heart is inflamed and there is some evidence of damage in the heart. And for the management, for the majority of the cases, they give non-steroidal plus colchicine. But following MI, they will give aspirin plus colchicine, but there is a lot of details in post-MI pericarditis, which should be discussed separately. Generally, the duration of the treatment will depend on the symptoms, on the signs, on how the patient responds, and the normalization of inflammatory markers such as the C-reactive protein. Thank you for watching, and please join us at our platform, the Mid-Empire. We have a lot of topics there. Thank you for watching.